What is going on, everybody? It's Medicosis Perfectionalis, where medicine makes perfect sense. Welcome back to my cardiology playlist. In previous videos, we talked about angina and myocardial infarction. We talked about cardiogenic shock, obstructive shock, hypovolemic shock, septic shock, neurogenic shock, and anaphylactic shock. We talked about cyanotic congenital heart diseases and acyanotic congenital heart diseases. We discussed rheumatic fever and infective endocarditis, dilated cardiomyopathy, hypertrophic cardiomyopathy, and restrictive cardiomyopathy. We talked about acute fibrinous pericarditis and constrictive pericarditis. We talked about hypertension and congestive heart failure. Then we talked about cardiac arrhythmias, and now we're discussing valvular heart diseases. We are done with aortic stenosis, aortic regurg, mitral stenosis, mitral regurg. Today it's time for mitral valve prolapse. As you know, the mitral valve lies between the left atrium and the left ventricle of the heart. Normally, the mitral valve should be able to close during ventricular systole. But what if instead of closing at this level or this plane, the cusps of the mitral valve bulge upwards and parachute like this? This makes the mitral valve weaker at closing, which increases the risk of mitral regurgitation or mitral insufficiency, which increases the risk of pulmonary edema. What are the causes of mitral valve prolapse? What are the symptoms? How can we diagnose it? How can we treat it? Let's find out. Click the like button, click the subscribe button because I'm already feeling some chest pain. This is my cardiology playlist. It has cardiac anatomy, physiology, pharmacology, and pathology. A quick review on the adult circulation of blood. Oxygenated blood returns from the lungs to the heart via the pulmonary veins into the left atrium. This oxygenated blood will be pumped from the left atrium into the left ventricle through the mitral valve. This oxygenated blood will be ejected from the left ventricle into the aorta through the aortic valve. This oxygenated blood will be distributed to every organ in your body. Each cell will take the oxygen in and the nutrients from the arterial side and dump the carbon dioxide and the waste products onto the venous side. Hashtag internal respiration, hashtag cellular metabolism. This deoxygenated blood on the venous side is going to return back to the right atrium. The deoxygenated blood will pass from the right atrium to the right ventricle through the tricuspid valve. Then the deoxygenated blood will be ejected from the right ventricle into the pulmonary trunk through the pulmonic valve, then to the right and left pulmonary arteries. Then the deoxygenated blood will go to the lungs. The lungs will get rid of the carbon dioxide through exhalation and bring some oxygen in through inhalation. And you repeat the same cycle again. Note that the heart has 4 valves: mitral valve, tricuspid valve, aortic valve, pulmonic valve. All of these valves have 3 cusps, except for the mitral valve. This mitral valve looks like la mitre, which is a religious hat worn by some Catholic clergymen. And as you see, this hat has 2 cusps, just like the mitral valve. That's why we call the mitral valve mitral. The mitral valve has another name, you guessed it, bicuspid valve, because it's the only heart valve with 2 cusps instead of 3. If you wish to see more videos like this in the future, drop a heart emoji in the comments. Mitral valve between left atrium and left ventricle. Tricuspid valve is between right atrium and right ventricle. Aortic valve is between left ventricle and the aorta. And the pulmonic valve is between the right ventricle and the pulmonary trunk. Each one of these valves can suffer from stenosis or regurg. What if I suffer from both? Then it's called double. There is double aortic, there is double mitral, double pulmonic, and double tricuspid. What's the difference between stenosis and regurg? Stenosis is a narrow valve that cannot open properly. Instead of being open like this, it is now open like this. Oh, this is narrow. This is difficulty at opening. Whereas regurgitation is difficulty at closing. It is supposed to be sealed, shut like this, perfectly closed. Instead, it could not close as much, which can lead to backward flow of blood, which is regurgitation. Put differently, stenosis hinders the forward movement of the blood, whereas regurgitation permits the backward flow of blood. That was profound. In the last videos, we talked about mitral stenosis and mitral regurg. Today, we shall talk about a special condition, mitral valve prolapse, which can be complicated by mitral regurg. Which means I can start with mitral valve prolapse and end up with prolapse and regurgitation of the mitral valve. The word regurgitation is synonymous with the word insufficiency. For the historians watching this video, mitral valve prolapse can also be called Barlow's disease or Barlow syndrome. If you wish to download these doozy colorful notes, go to medicosisperfectionalis.com. I help you learn, understand, and pass exams. If you want me to personally tutor you, reach out to me on my website. This is the left atrium, this is the left ventricle, this is the mitral valve in between. How many cusps? It's bicuspid. It has 2 cusps. During ventricular systole, the mitral valve is supposed to close like this, so this is normal. But what if the mitral valve is parachuting upwards like that? Now this is called mitral valve prolapse. But can we be specific when we say parachuting? Sure. Mitral valve prolapse is defined as the bulging of one or both of the leaflets of the mitral valve 2 millimeters or more above the plane of the annulus of the mitral valve. Can we measure this specific distance via echocardiography? You can bet your gluteus maximus we can. And let me tell you something important. Just because we have mitral valve prolapse doesn't necessarily mean that we have regurgitation. I could prolapse, I could just bulge, but still be fully closed during systole. However, if this becomes severe enough or late enough, then failure to close the valve can result in mitral regurgitation later. Can I tell the difference between mitral valve prolapse and mitral valve regurgitation without an echo? Yes, bring your stethoscope and let me teach you some things. If it's just prolapse without the regurg, then you're gonna hear the famous mid-systolic click. When you parachute, you click. This click is not an ejection click, unlike the click of aortic stenosis, which was an ejection click. The click of mitral valve prolapse could be mid-systolic or late systolic, whereas the click of aortic stenosis was early systolic. So that's it. If it's a prolapse only, it's a click only. But what if it's a prolapse with regurg? Then you're gonna hear a click followed by a murmur. Is it systolic or diastolic? Let's think about it. Mitral regurg is failure to close the mitral valve. But when is the mitral valve supposed to close? It is supposed to close during ventricular systole, and therefore mitral regurgitation is a systolic murmur. Normally, you close the mitral valve during systole. This is mitral valve prolapse, and this is prolapse with regurg. If it's just mitral valve prolapse, you hear a mid or late systolic click, which is best heard at the apex of the heart in the left fifth intercostal space mid-clavicular line. If it's mitral valve prolapse and mitral regurgitation, then I'm gonna hear the click during systole followed by the systolic murmur. Now get your pens and paper ready and doodle with medicosis. We need to draw right atrium, right ventricle, and left atrium, left ventricle. This is the interatrial septum, this is the interventricular septum, and this is the mitral valve, and it has 2 cusps. Mitral valve prolapse. If it's just prolapse, just the parachuting action with no regurg, well, most patients are asymptomatic. But what if it starts to regurg? Oops, now the blood is leaving the left ventricle and entering the left atrium with vengeance. Eventually, the left atrium will give up and all of that blood will accumulate in the pulmonary veins and then will back up into the lungs, which can lead to pulmonary edema, including alveolar edema, interstitial edema, and even pleural effusion. Symptoms will include shortness of breath, which is dyspnea, orthopnea, paroxysmal nocturnal dyspnea, cough that is productive with sputum. The sputum is pink and frothy. Why pink? Because of the blood. Why frothy? Because the lungs have air. Exercise intolerance is also common. Now take a look at this. The left ventricle is giving some of its blood to the left atrium, which means that less blood will enter the aorta compared to normal, which leads to less cardiac output. That will be less blood to the coronary arteries and less blood to the heart itself. Welcome to the land of angina or myocardial infarction. Angina is ischemia. MI is infarction. Angina is reversible. MI is irreversible. Angina is cell injury. Infarction is cell death. This is ischemic heart disease. How about ischemic brain disease? The equivalent of angina in the brain is called transient ischemic attack. That's the injury. The infarction in the brain is known as stroke. That's the cell death. Reversible, irreversible. So angina is equivalent to TIA and MI is equivalent to stroke. Who else is going to teach you like this? Your professor with his PowerPoint? Give me a break. That's why you need a medicosis in your life. Next, thinking beyond stage 1. What do you think is going to happen when the left ventricle gives some of its blood to the left atrium? Well, the left atrium will return that blood back to the left ventricle through the mitral valve in the next cardiac cycle. Now the left ventricle is receiving more blood from the left atrium than normal because the left atrium has blood from two sources now, from the normal source, which is the pulmonary veins, and from the abnormal source, which is the blood from the left ventricle. This increases the left ventricular end diastolic volume, otherwise known as preload. And when you increase the preload on your ventricle, what's going to happen? According to Frank's Starling law, if you give me more blood, I will contract with a greater force. So contractility increases, and the left ventricle pushes harder and harder and harder and ejects harder and harder and harder. This eventually leads to left ventricular dilation and eccentric hypertrophy. So what's going to happen to the point of maximal impulse of the heart? It will be displaced. The apex of the heart will be displaced from the left mid-clavicular line to the left anterior axillary line or left mid-axillary line in your smelly axilla. When there is volume overload, i.e. increased preload, as in cases of aortic regurgitation and mitral regurgitation, we expect the ventricle to dilate eccentrically like this. So it's dilated and eccentrically hypertrophied. But in cases of pressure overload or increased afterload, we expect concentric hypertrophy from the left ventricle. Mitral valve prolapse can lead to mitral regurgitation, which increases the preload on the left ventricle, so it dilates and undergoes eccentric hypertrophy, and this can displace the point of maximal impulse, i.e. the apex. Mitral valve prolapse syndrome is the same as mitral click murmur syndrome, is the same as Barlow syndrome. What is mitral valve prolapse syndrome? How is that different from simply mitral valve prolapse? Let me tell you. Mitral valve prolapse syndrome has the name syndrome. What does syn mean? Synchrony. Together. Oh, symptoms? Several symptoms coming together. What kind of symptoms? Mitral valve prolapse and associated symptoms. Could be palpitations, could be autonomic dysfunction, or could be pectus excavatum. Many patients with mitral valve prolapse have low BMI or body mass index. Mitral valve prolapse in general is more common in females than males. But when males get it, it's usually more severe, i.e., it is more likely to deteriorate and progress until it requires surgery eventually. Mitral valve prolapse could be classified into mitral valve prolapse syndrome, which has the prolapse and associated symptoms. This one is more common in females than males. The average age is between 20 and 50. It is usually benign. Next, myxomatous mitral valve disease, more common in males than males. Average age is between 40 and 70. The prognosis is usually worse when you compare it to the first one. Then we have secondary mitral valve prolapse, secondary to another disease. So patients with Marfan syndrome can develop secondary mitral valve prolapse. Patients with Ehlers-Danlos syndrome can develop mitral valve prolapse. Patients with pseudoxanthoma elasticum can develop secondary mitral valve prolapse. Other connective tissue diseases can lead to mitral valve prolapse. Even hypertrophic cardiomyopathy can lead to mitral valve prolapse. But why is this? Remember that we have left ventricular wall, left ventricular cavity, left ventricular outflow tract, and then the aortic valve. There is an anatomical proximity between the left ventricular outflow tract and one of the leaflets of the mitral valve. And therefore, in hypertrophic obstructive cardiomyopathy, the approximation of the thickened asymmetrical interventricular septum is gonna pinch and grab one of the leaflets of the mitral valve this way. Oh, making it harder for the mitral valve to close, or making it easier for the mitral valve to bulge upwards during ventricular systole. And that's why hypertrophic obstructive cardiomyopathy can lead to mitral regurgitation. Do you want to learn more about the anatomy of the heart? Check out my anatomy playlist. It has review videos for anatomy of the head and neck, anatomy of the upper extremities, lower extremities, thorax, abdomen, pelvis and perineum, neuroanatomy, and even embryology. Each one of these topics is covered in 3 separate videos. So, part 1 of the thorax is called Quick Review, part 2, Anatomy of the Thorax, is called Ultimate Review, and part 3 is titled Clinically Oriented Anatomy of the Thorax, and we repeat the same process for each one of them. So, in about 24 videos, you will know more anatomy than most doctors. Again, what is the definition of mitral valve prolapse? Bulging of one or both of the mitral valve leaflets 2 millimeters or more above the plane of the mitral annulus. Mitral valve prolapse can lead to mitral regurgitation. Regurgitation is failure to close. The mitral valve is expected to close during systole, and that's why mitral valve prolapse and mitral regurgitation are systolic murmurs. So, between S1 and S2 heart sounds, we have systole. So, if it's just mitral valve prolapse, expect the mid-systolic click. But if it's prolapse and regurg, then it's going to be followed by a regurgitating murmur that looks like this. This is a mid to late systolic murmur, heard best at the apex of the heart. And where is the apex of the heart? It's in the left 5th intercostal space, mid-clavicular line, usually half an inch below the nipple. Now, some doofuses will say that the apex is 4 inches away from the sternal border, but that's a load of bilge water. What's the problem with that definition? The problem is that some people are thin, other people are obese, some people are young, some people are old. So you cannot just mark the apex by its distance from the sternal border. That's nonsense. The accurate way to describe it is mid-clavicular line. Because if you are a tiny individual, then your clavicle will be tiny. And if you are a big individual, usually your clavicle is big. So your mid-clavicular line should be your landmark. Moreover, you can feel the patient's apex with your fingers. Here is S1 heart sound, here is S2. Lub and dub. Between S1 and S2, we have systole. Mitral valve prolapse is a systolic murmur. We have a mid-systolic click followed by a murmur of regurgitation. Notice the difference between the click of the mitral valve prolapse and the ejection click of aortic stenosis. The ejection click of aortic stenosis is early systolic, whereas the ejection click of mitral valve prolapse is mid to late systolic. Here is another key difference between the click of aortic stenosis and the click of mitral valve prolapse. The click of aortic stenosis is an ejection click, but the click of mitral valve prolapse is a non-ejection click. Here is S1, here is S2, and here's the following S1. This is systole, and this is diastole. Here is the mid-systolic click, followed by the murmur of mitral regurgitation. This is best heard at the apex of the heart. If there is regurgitation, it might radiate to the axilla. Did you know that some maneuvers will make the click happen earlier, whereas other maneuvers will make the click happen later? How? Back to physics. Are you familiar of the difference between laminar flow and turbulent flow? Sure. Laminar flow, well, we have lamina, we have layers of nice fluid flowing in harmony, in order. This causes no noise, which means you cannot hear this flow with your ordinary stethoscope. Maybe, just maybe, with practice, the Lionel Messi of cardiologists, using the Rolls-Royce of stethoscope, after years and years and years of practice, may be able to hear the laminar flow with a stethoscope. But this is very difficult for the ordinary student to do. However, If I have a disease in the valve, it creates turbulence in the flow, and this turbulence causes noise. This is what you call a murmur, and you can definitely hear this with a stethoscope. With most heart murmurs, if more blood flows through that sick valve, you will hear a louder murmur. And if there is less blood, you will hear a lower murmur. This is true for all heart murmurs, except two famous exceptions: mitral valve prolapse and hypertrophic obstructive cardiomyopathy. In which case, more blood will give me less murmur, whereas less blood causes more murmur. What do I mean by this? In most cases, squatting does what? It increases the preload and the afterload. This makes more blood enter into the heart. More blood passes through the valve, causing a greater murmur. But in mitral valve prolapse and hypertrophic obstructive cardiomyopathy, squatting causes more blood to flow by the sick mitral valve, which causes less murmur and a later click. So the click tends to happen later, i.e. mid to late systolic, usually late systolic. How about hand grip? It increases afterload and increases blood, and with most heart murmurs, it makes the murmur more intense. But not in mitral valve prolapse and HOCM. Those are the exceptions, where hand grip increases the afterload, increasing blood flow through the sick mitral valve, which decreases the murmur, makes the click happen later. Leg raising, more preload, more blood flows by the valve, more murmur. Not in mitral valve prolapse and HOCM, where leg raising increases blood, less murmur, later click. Valsalva decreases the venous return, decreases the preload, decreases the blood that flows by the sick valve, causing less murmur. But not in mitral valve prolapse and HOCM, where Valsalva decreases venous return, increases murmur. Less blood, more murmur, and an earlier click. The same thing happens when I stand up suddenly. Less blood, more murmur, earlier click. If you want to learn more about hypertrophic obstructive cardiomyopathy, I have a special video on this topic, and you can find this video in my cardiology playlist. The effects of mitral valve prolapse and therefore mitral regurgitation on the pressure-volume loop and on the blood pressure in the aorta, left ventricle, and left atrium was discussed in the previous video titled Mitral Regurgitation, which you can find in this cardiology playlist. Here is everything you need to know about mitral valve prolapse in one slide. Again, you can download these doozy notes on my website, medicosisperfectionalis.com. What causes mitral valve prolapse? Myxomatous degeneration, connective tissue diseases such as Marfan syndrome, Ehlers-Danlos syndrome, see my biochemistry playlist, pseudoxanthoma elasticum, congenital deformity of the valve, defective embryogenesis, and hypertrophic cardiomyopathy. Many patients with mitral valve prolapse tend to be of low body mass index and tend to suffer from atrial septal defect. Not all of them, but many of them. Symptoms. Most patients with mitral valve prolapse are asymptomatic, especially if it's just a prolapse without mitral regurgitation. If there is mitral regurgitation, less blood will enter the aorta, less blood will be distributed to the organs, so we get less cardiac output symptoms. Low cardiac output symptoms include in the brain, TIA and stroke, in the heart, angina and infarction. In the muscles, less blood flow equals muscle weakness. In the kidney, less blood flow equals pre-renal azotemia, which causes oliguria. And this is the famous motto of nephrologists, which is no BP equals no PP. What does that mean? If the kidney is not perfused enough, it will not make urine for you. This should be written on a t-shirt. Many patients with mitral valve prolapse start to suffer from cardiac arrhythmia such as supraventricular tachycardias, Wolff-Parkinson-White syndrome, and prolonged QT interval. And we can find these on EKG. Physical exam findings. If it's just a prolapse, mid-systolic click. It could be mid to late. If there is mitral regurgitation as well, it's a click followed by a murmur, best heard at the apex, might radiate to the axilla. Keep in mind that mitral regurgitation radiates to the axilla, but mitral stenosis murmur does not radiate. For the most part, if there is mitral regurgitation and left ventricular dilation and hypertrophy, we expect the point of maximal impulse, or the apex, to be displaced laterally, and maybe a palpable thrill and a left ventricular heave or lift. If there is volume overload, expect S3 gallop rhythm. Because the mitral valve cannot close properly in mitral regurg, we might find diminished S1. How can we diagnose mitral valve prolapse? History, symptoms, signs, and then you do an echo. The moment you hear a murmur with your stethoscope, the next step should be an echocardiography. The echocardiography will measure the distance of the bulge. If the bulge and parachuting of one or both leaflets is 2 or more millimeters, this fits the definition of mitral valve prolapse. EKG, we might appreciate the SVTs, Wolff-Parkinson-White, or prolonged QT interval. Left atrial enlargement, left ventricular enlargement can happen only if there is mitral regurgitation, not simply from the prolapse. Chest X-ray, left atrial enlargement, left ventricular enlargement, and curly B lines, and cephalization if there is pulmonary congestion, only if there is a regurgitation. Cardiac MRI can help, and cardiac cath. How can we manage mitral valve prolapse? Non-pharmacological therapy includes salt restriction, caffeine restriction, nicotine restriction. Medical therapy. If we have palpitations, give beta blockers. If we have a risk of TIA or stroke, give aspirin. If we have a risk of endocarditis, antibiotics. The recent guidelines does not recommend giving antibiotics if the patient only has prolapse of the mitral valve. Next, surgical options. If the mitral valve is toast, you can repair it, valvotomy, or you can throw it in the trash and replace it with a new one. This is called mitral valve replacement. You can replace the mitral valve with a tissue valve called bioprosthesis, usually from a pig or another animal, or you can replace it with a metallic valve known as mechanical prosthesis. When should we replace the mitral valve? When the left ventricular ejection fraction is low, lower than 60%, or when the left ventricular end systolic diameter is greater than 45 millimeters, which tells you that we have dilation of the left ventricle. To learn about beta agonists, beta blockers, alpha agonists, alpha blockers, the adrenergics, the cholinergics, the nicotinics, the muscarinics, etc., download my autonomic pharmacology course at medicosisperfectionalis.com. It comes with videos, notes, and cases. To learn about the antiarrhythmics, antihyperlipidemics, antihypertensives, anti-anginal medications, diuretics, and even digoxin, download my cardiac pharmacology course at medicosisperfectionalis.com. To learn about angina, myocardial infarction, ischemic and hemorrhagic strokes, cardiac arrhythmias, ARDS, the tox syndromes, and more, download my emergency medicine high yields course at medicosisperfectionalis.com. Join thousands of students who study using my courses. If you value what I do, help me make more videos by supporting the channel. Go to buymeacoffee.com/medicosis. There are more than 600 premium videos available on this channel when you click the join button and choose the highest tier. Please subscribe, hit the bell, smash like, support my channel on Patreon, PayPal, or Venmo. Go to my website to download my courses, notes, and cases, or if you would like me to personally tutor you. Be safe, stay happy, study hard. This is Medicosis Perfectionalis, where medicine, chemistry, math, and physics make perfect sense.